what I have found and seen and learned is that physicians are quite dialed into how they're being judged externally for the quality of their work. And I think that is how you get physicians excited about documentation changes, right? Like, how do you convince them that and incentivize them that, hey, this is really actually important that you document completely around this perforated appendix, right? That you really capture how sick this patient is, and there are reasons both for risk adjusted payment, but risk adjusted quality measurement, right? How you're being judged, how your organization is being judged, and so that's one thing we really struggle with and try to use technology to sift through all these queries for more information and to improve documentation. I mean, your in-basket is full of crushing chest pain, Flonase refills, and CDI queries, right? And so how to sift through those, how to organize and prioritize those.
Welcome to How I Doctor, where we're bringing joy back to medicine. My guest today is Dr. Travis Bias, a board-certified family physician who spent the better part of a decade as Deputy Chief Medical Officer of Health Information Systems at Solventum, the healthcare spinoff of 3M, leading AI strategy for one of the largest health information system businesses in the world. Before that, Travis taught medicine in Uganda and Kenya, earned a diploma in tropical medicine and hygiene from the London School of Hygiene and Tropical Medicine, and has somehow maintained 48 active medical licenses, a fact that I'm still processing. Travis has kept one foot in clinical practice through all of this, and recently started a telemedicine travel clinic as well. Most people talking about AI in medicine are either building it or practicing it. Travis is doing both. I'll be back with Travis right after a word from our sponsors.
Before we jump into the episode, I want to thank our sponsor, Evidently. Evidently is the clinical data intelligence platform built to help physicians harness the ocean of patient data they're drowning in every day. From chart summarization to AI-assisted note drafting and denial appeal support, Evidently makes sure the right data shows up at the right time. Physicians using Evidently report spending less time hunting through charts and more time focusing on patient care. That's why they've become a trusted partner to health systems looking to improve documentation, quality, and revenue sustainability. The company is led by providers and AI researchers that are dedicated to reducing documentation burden and helping clinicians practice at the top of their license. If you want to see what Evidently can do for your hospital or your practice, reach out today at www.evidently.com. Now, let's get into today's episode. Before we jump into the episode, I want to thank our newest How I Doctor sponsor, Savaro. Savaro is a top telestroke and neurology company that was built to fix one of the most predictable failures in modern medicine, getting timely, consistent access to a neurologist when you actually need one. Their team of board-certified neurologists deliver rapid video response, clear decision-making support, and continuity from the first exam all the way through treatment planning and management. Hospitals working with Savaro see faster door-to-needle times, fewer transfers, and measurable improvements in patient outcomes. And because Savaro was built by physicians, the workflows actually match real-world medicine. If you need stronger, faster, and more predictable neurology coverage, visit savaro.com to learn more. And now, let's get into today's episode.
Dr. Travis Bias, welcome to How I Doctor. Travis, thanks for being here.
It's an honor. I appreciate what you're building.
I would imagine a lot of doctors probably have not heard of Solventum. I hadn't before I met you. What do you guys do?
So Solventum is the former 3M healthcare business, as you stated in the intro. And so we've been a standalone healthcare company for just over 2 years now.
Yeah, you see the logos.
Many people know 3M products and Solventum products now from medical and surgical supplies you might touch and feel in the hospital. And so we have a health information systems business that's been around for a little over 40 years. And actually, we started as kind of owning and developing the diagnosis-related groups, or DRGs, which many people are familiar with, which how you effectively risk adjust hospital payments, inpatient payments. And we have kind of housed and evolved those population health methodologies into things that can stratify populations for outpatient payment, for risk adjusting and risk stratifying populations. And then building upon that, we built this coding platform or coding software that's now used in 80% of US hospitals, essentially. And so people are very familiar with that. Kind of on the back end, physicians may not be as familiar with that, but they might be familiar with some of the CDI or clinical documentation integrity systems or products that they might see to really try to improve the efficiency within which they capture the complexity of their patient populations every day. And so that's really kind of what we are known for. About 6 years ago now, we acquired Modal, which is a front-end speech recognition, natural language processing company, basically, which is used by 200,000 physician users across the U.S. And many globally, increasingly, as far as front-end speech, and then of course ambient documentation solutions. I hear there are a few other folks that have built solutions like
I've
that.
heard of those.
But they're, this is something that has kind of come as a natural evolution of that business over the last 20 years, effectively. From they were a transcription company, which then built into a front-end speech company, which then informed the learnings that it built our ambient documentation solutions. And so within that, there are a lot of computer-assisted physician documentation, or CDI, tools that, again, the goal is to improve efficiencies around capturing completely and accurately the complexity of your patient population.
Okay, now here's a question. Are DRGs used outside the US?
Absolutely.
I thought that was like an American thing.
No, there are different forms. So there are MS-DRGs that CMS actually, we maintain those for CMS, actually. But then there are APR-DRGs, so all patient-refined DRGs that actually handle all populations.
We could just do acronym city. This whole interview, we could just do speaking acronyms.
We wrote the book on acronyms, man. Do not take that from us. But no, I mean, there are IR-DRGs used internationally. And so every country kind of has different versions of these DRGs that we are creating and maintaining for them.
Okay, that makes sense. So other countries are categorizing, organizing their patients the way they want to, and you guys are maintaining that and supporting that for them.
That's exactly right. And then they use different, diagnostic coding tools and procedure coding tools, right? So ICD-10 is not actually used in every single country. And CPT, by the way, is not used in every single country, right? They're different. Either local countries have created their own procedure coding tools or a version of something that might use similar to CPT and might leverage SNOMED and other solutions. This is stuff that was like not interesting to me 7 years ago, but the more I've kind of peeled back the layers of the onion, I mean, it is critical data that we need for at a population level. If you're really trying to impact health and lower costs, you have to have some form of discrete population data fields, not just long narratives that we might take pride in as primary care physicians or your emergency department physicians like yourself.
I was talking with Eric Topol last year on the podcast about, he believes that we'll just have these big data sources, and we will have way more personalized care for each of us. That, your genetics plus your past medical history plus the meds you take plus maybe your zip, whatever it is, nomial risk formulae will determine things. It's kind of interesting. How do we group people when everybody is fundamentally like an N of one? Do you have thoughts on how do we handle the personalization, but then we're trying to group things so that we can make better decisions?
I think that AI is going to enable that feature that you just described, that Eric Topol described, that there's a way to capture more granularly what is unique about that patient and what is unique about that patient population. And the whole AI scribe deployment over the last couple of years, I think, is showing that. We had a lot of early physician users that told us that these solutions are capturing more than they would typically capture in their documentation, right? So if it's not making it into the documentation, it's not going to make it into whatever data source you're using to group the patients and to pay for that inpatient admission, pay for that outpatient visit, pay for that population over a period of time. And so I do think AI is going to enable that further. I think that, and then that will help properly incentivize high value care, right? I do think that future is coming. There just needs to be kind of a policy or political choices then around, how you're going to allocate those resources in a unique way. I mean, I think too, the personalization is important. I do think right now we have a pretty good way of deciphering, hey, there's a large urban population that has very different needs than a rural population. A middle income country, rural population has very different needs than downtown Oakland, California.
I think the interesting other challenge is just that the ability for us to both generate and then process that data, especially honestly because of AI more than anything else, I think now just way exceeds the regulatory or payment frameworks. We could run Claude on all of whatever Stanford's EHR data and extract all this information. We could come up with 10,000 new groups of people that we didn't know. And we could say, yeah, hey, these patients are more complex. We should pay these doctors more for these and less for those. But the regulatory framework, I mean, you and I know politics and regulation could be 2 weeks away or it could be 20 years away, frankly.
Multiple opinion pieces right in the last year or two have described what you're talking about as far as this regulatory lag and really this systemic lag behind what the AI capabilities really are. And yeah, at the US level, I mean, it's it's kind of every state for themselves right now as far as coming up with what that regulatory paradigm is going to look like, for better and for worse, right? Like, I understand there's this excitement around innovation, but you and I both know there are frontline clinicians that are plenty skeptical about how and where AI is impacting their daily work. And so I think that's where regulation's really going to have to keep up quickly, or the horse is going to be out of the barn.
Yeah.
If you will.
Yeah, completely.
And maybe already is,
Yeah. It's interesting where you sit because I think a lot of physicians don't trust that the metrics really capture what they actually do or the actual patient in front of them. There's the patient, and then there's like the e-patient, the EHR representation of the patient, and then there's another abstraction further than that that's like, appendicitis with perforation, which is like this way oversimplification. Sometimes it's not oversimplified, but often it's way oversimplified the human being in front of them. Maybe administrators don't think that physicians are always engaging with that data. Like, how do you think about this working at a company that does DRGs and metrics and coding and grouping, but then you're also a practicing doctor too?
What I have found and seen and learned is that physicians are quite dialed into how they're being judged externally for the quality of their work. And I think that is how you get physicians excited about documentation changes, right? Like, how do you convince them that and incentivize them that, hey, this is really actually important that you document completely around this perforated appendix, right? That you really capture how sick this patient is, and there are reasons both for risk-adjusted payment, but risk-adjusted quality measurement, right? How you're being judged, how your organization is being judged, and so when you get these messages, that's one thing we really struggle with, and try to use technology to sift through all these queries for more information and to improve documentation. I mean, your in-basket is full of crushing chest pain, Flonase refills, and CDI queries, right? And so how to sift through those, how to organize and prioritize those, whether it's in your in-basket or maybe in another CEPD tool, either sitting on top of the EHR or sitting within the EHR.
How do you think they are being externally judged?
There are, many. There are different payer schemes and mechanisms, right? But there's U.S. News and World Report. I mean, I think that's a huge one for organizations that they're continually tracking, or even within, Vizient, right? Like there are different analytics platforms like Vizient that a lot of organizations are using to really judge kind of, what were your mortality rates, for example, in patients who had a recent heart attack? Well, that can be very much risk adjusted on a variety of means, as far as kind of how were they a smoker? Did they have something that was present on an admission? There are a lot of different places where you can improve documentation completeness that then alters how your mortality is judged. And even simple things, and sometimes in that surfaces something like, hey, maybe we are not capturing our patients that are, DNRs that basically ought to be under hospice care or something like that. Maybe they should be taken out of the denominator. And so that's really, I think, a way that some of the incentives start to kind of come together, and some of the physician advisors get with their frontline physicians to paint that picture about, hey, this is how we're getting our analytics platform is saying this about your care. The frontline physician says, well, my patients are sicker and have my patients, I have more DNR patients than the average. Okay, well, that's great. Let's document that and capture that. And let's make it easy for you to capture that in the EHR.
A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights, chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today. I want to take a moment to thank our sponsor, Savaro. If you've ever waited and waited for a neurologist to call you back, you know the problem that Savaro was built to fix. Savaro is a physician-led telestroke and neurology company that delivers rapid virtual neurology coverage that's reliable. Their board-certified neurologists connect by video in under 45 seconds, and they stay with you through the entire decision-making journey. Hospitals working with Savaro report faster door-to-needle times, fewer unnecessary transfers, and measurable improvements in patient outcomes. If your hospital needs stronger, faster, more consistent neurology coverage, visit Savaro.com to learn more.
I think all physicians would say there are physicians that are better physicians and worse physicians. We can say that two surgeons, you can probably see one surgeon who's like a really good surgeon with perfect sutures and another one who's a little bit rougher with the tissue, for example, right? So we agree that there are differences between individuals, but then, how do you manage that when maybe one surgeon is willing to take someone to the OR who will likely die, but they want to give them a fighting chance, and the other one says, the OR is so risky. I actually think it's too risky to do surgery and we should try to manage you medically and stabilize you. It feels like it's a problem of the universe, that there is not a way to both acknowledge that there are differences between individuals, but then take into consideration a lot of the factors like you just mentioned. More of my patients are DNR. I only work night shifts, and so I don't have access to ultrasound. I don't know. It feels like it's such a complex problem.
Yeah, that one's super challenging because you have to parse it out by what's the risk of the patient, the individual risk of that patient. What's the risk of the procedure, and what's the resource utilization of that procedure specifically? What's the capacity of that hospital and that organization to take on that? And so that was a lot of things we were thinking about after COVID, really in the heat of COVID, right? Like there are true resource constraints going on right now. So how do we think about, when ORs were closed for a long period of time, we're reopening them. Well, let's maybe do focus on some of the lower risk procedures, maybe outpatient procedures or things that you don't anticipate or will need intubation, or long hospital stays afterwards. Won't need an ICU stay, won't need blood products, and maybe take some of the lower risk patients earlier on. Unfortunately, but things to the OR reopening up without slamming the hospital capacity as far as inpatients. And so I think that's something that physicians have been incredibly frustrated by, especially in primary care, where obviously the measuring the holistic output or outcome of our inputs of our cognitive skills and resources that we put forth in our practice, it feels very challenging. Back to your point about some of the judgment of quality in the inpatient space.
Yeah, and even if we did document every piece of that, it's probably going to be like the physician expected to add that to their note, right? That we don't really have a system that takes a snapshot of the ER trackboard as I'm writing my note to say, oh my God, Graham was managing 20 patients at one time when this happened, and there were 3 nurses that called out sick, and our CT tech that was, one of the CT scanners was down, like all of those other factors. We don't have a way to track, recognize them unless I jot it into my note, which then gets to the problem of you didn't document enough.
That's probably when your documentation gets worse, right? Is when you're strapped for time to really, and that's when documentation of some of those pieces goes down. And but you're right, it's very difficult to capture some of those things, and when we're fully relying on documentation, and that's where I see some of these AI tools really coming in to help.
Travis, when you meet with health system customers, how does your position and perspective as a physician impact what you say to them, how you talk with them?
I really enjoy that role, actually, because I see myself as a translator between what our customers are needing and wanting and what our product teams can produce, basically. And I love being that kind of in-between translator. And so when we're talking with a client of any kind, physician, clinician or not, I see myself as kind of, you know, being curious basically and asking and digging deeper into what are they really trying to do here with the technology that we have? What are they really trying to solve? And if I can get to the root of that, and it's similar to talking with a patient, right, and asking probing questions about what's really going on here, and then I would like to think as a physician messenger for Solventum, in these conversations, I think maybe the language we use is a little bit different. I don't know, but it seems to be received well, and I think part of it too is just. I guess I'm a pragmatist as a family physician. I want to be very blunt and upfront with people about, hey, this is what the technology is actually designed to do versus what it's not designed to do. And so I think setting expectations realistically up front is way better than having a customer 6 months down the line saying, hey, I thought it did this and it's not doing that.
I actually think health systems would do better if they gave their physicians a little more time for training and education. Like I have this theory that, like I think in 2023, 2022, the AMA changed the like billing and coding guidelines for outpatient notes and ER notes and hospital notes about like, you don't have to do the 10 review systems things anymore.
Right.
I would bet $20, $100 that like at least 30% of doctors across this great nation are still documenting. They may know they don't have to, but it is just in their core.
Yeah. I'll bet it's
They've
higher
been
than
doing
that.
it for a decade. They don't know that they don't have to document no thyromegaly, and they can still get full credit for a very complex patient that they're working really hard with. And it's like training and muscle memory, and it's maybe a little bit of like permission from the health system to say, hey, I'm telling you, here's the formal memo.
Mhm.
You don't have to do this anymore. It's great to take you should
Mhm.
still do review systems. You don't have to document no thyromegaly anymore, and you can still get full credit for whatever, a level 4 visit, a level 5 visit, whatever it is.
I do think you're right. I think there's still a lot of over documentation happening. And there are a lot of notebook initiatives, right,
Oh,
to trim
sure.
down
Yeah.
on that. We know that there are notes, especially in the inpatient space, that are just so lengthy just because we think there's still these kind of cultural habits that we still think we have to document all those pieces. And you're exactly right. I think there is a little bit of relief now to focus on the MDM and time mainly, but I'm sure there's something lost in that, right? Where we're going back to then not having as much documentation data that could actually be useful. Some of these new summarization tools and things that are being used, I think, can help us sift through that. But yeah, I mean, some of these people have 10, 20 years in Epic, or their whole lives are in the EHR somewhere.
Yeah. We have patients that were born in a system and have their entire care since, at Kaiser since 2006. Crazy.
Which, I mean, there are massive benefits
Of
of that,
course,
right? Yeah,
yeah.
the patient that's born in Kaiser and is now 17, and there's no sifting through or faxing for records from outside organizations. But then there are some nuggets in there that are certainly hard to find, or there's still needles in the haystack in there that are difficult to
Yeah.
find. So um, that's an AI tool right there, that summarization piece that's really going to help things once physicians trust it. I think that's another challenge, right? Is some of these summarization tools may gloss over something that's actually important to me as a primary care physician.
Travis, I'm gonna totally change our topic here. I want to talk about your global health work, and tell me a little bit about what global health work you've done in the past before this role.
I taught medicine for a little over a year in East Africa. First, I taught in a family medicine residency program that was getting up and going in central Kenya at Kabarak University.
Shout out Kabarak.
Yeah, shout out to Meru County. That's in central Kenya in the base of Mount Kenya, beautiful area. I was there for 4 months teaching 10 different medical officer interns and 2 family medicine residents. So there, some people just do 1 year of an internship after medical school, and they become kind of a generalist or a GP, working in a variety of services across the public health system. Or you can go do a master's in medicine in whatever specialty. Basically, that's your residency residency training, postgraduate training. So they were doing a 4-year MMed in family medicine, and so that was a lot of fun. It was a huge growth experience, right? I'd just done that diploma in tropical medicine and hygiene. That was in East Africa for 3 months. And so I learned a lot more about HIV, TB, malaria, things that a family medicine program in Houston is not going to have you, fully trained up on, right? Because the infectious disease specialists tend to take that here in the States. And so after that program in central Kenya, I switched to a Peace Corps. It was a public-private partnership between the U.S. Peace Corps, funded by PEPFAR, and also SEED Global Health. SEED was the private organization, and went to teach I was there for a little over 8 months in eastern Uganda, the fourth public medical school there, Busitemma University. And there I taught fourth-year medical students. It was their first clinical year in medical school. So you think of third year here in the States. And a lot of it's just about synthesizing a bunch of information to take care of the patient in front of you, right? And so a lot of it is kind of, you can read this long story, but can you actually decide what to do next for that patient? In both those settings, the reliance on physical exam is heavy because they don't, have the resources to CT everyone, or they don't have the resources to be doing all kinds of labs and just, imaging on folks sometimes. And so those physical exam skills really come in handy, and their physical exam skills far surpass anything I probably ever had in my career, which was something I had to kind of relearn a little bit.
Did you get a sense that patients had maybe a different level of trust in the health system or their doctor, their nurse in East Africa than maybe here in 2026?
That relationship's definitely very different. I would say yes and no. Yes, in the sense that there was not as much, Googling of what the plan ought to be, if that's what you're getting at. But not as many questions as far as like, hey, you're recommending this course of action. But where the lack of trust may have come, or any kind of distrust that was present, it was a lot more about, can the system deliver what my doctor thinks I should do? So can I get the labs I need? Can I get the imaging I need? Is the ultrasound tech there only on Tuesdays? Is the person there to draw my labs? I think it was more about, can the system deliver on my needs, rather than, are the health workers telling me something that's actually grounded in evidence and actually for me?
Well, I just imagine sometimes in the U.S., you can say, yeah, I think you're okay. I'm not really concerned about this.
Yeah, that's primary care a lot.
Yeah, fair. And a little bit of emergency medicine too. And I think sometimes in the U.S., patients say, well, can we do X to be sure? Can we do a lab to be sure? Can we do a CAT scan? Because I just don't know. And I would imagine that's not really an option for some patients in Eastern Africa.
I think that might be quite similar across systems, actually. And one of the reasons there is, the CT example, can we do a CT just to be sure my headache is not something that's life-threatening? Well, unfortunately there, the $100 CT, that's going to be paid for almost fully out of pocket by the patient. So if you want to do it, knock yourself out. Versus here, I think with third-party payers and others in the mix, there's a little bit of a different conversation there, right? Where if my copay is $30, we'll just get the MRI, right?
Yeah.
I do think there maybe is a little more of an acceptance of like, hey, you're fine, like let's just give it another week or two, just because maybe the cost implications. But really, like some people, especially those in the higher income status, and might want to go ahead and just get that CT or something. Yeah.
You mentioned the physical exam. What other things do health systems in East Africa do better than the U.S.?
The first weeks of COVID, I think, highlighted a huge difference between a U.S.-centric system and a system in East Africa, for example. So in Kenya, Uganda, non-pharmaceutical interventions, so masking, hand washing, social distancing, isolation, quarantine, these are not foreign concepts at all. And they know this stuff like the back of their hand. So they've been having Ebola outbreaks since the 1970s. And the treatment is to identify and isolate Ebola patients. I mean, that's essentially the treatment, and the spread stops, right? And so that's why most of the Ebola outbreaks you never read about in the media, because they get stamped out after 10, 20 patients in a community, because most health workers are trained to identify viral hemorrhagic fever when it walks in the door.
There's community health workers. That's not a thing here.
Absolutely. Yeah. There's a whole army of community health workers that are doing a variety of things. And so I think that was one thing that stuck out to me big time, where, we were fighting, well, should we mask? Should we not? What do we do? What, you have to stay indoors? Like there were all these things that in isolation, quarantine, forget it. Those were things that I think were such foreign concepts in the U.S. because we're just so used to having a quick medication, or some other kind of quick answer. You mentioned community health workers. I think that's a great call out. That's something that, even beyond, maybe like a pandemic threat, but even something like an HIV or something that's kind of now widespread, you've got community health workers and even expert patients. So through task shifting, you really are using community health workers and expert patients even to help manage HIV patients, to screen for early opportunistic infections, make sure people are taking their antiretroviral therapies. And so that's something that we really don't have as much of infrastructure for. There are a lot of good community health worker studies and programs building up in the US, but that's something we could absolutely leverage better. And I think overall, maybe just, there's just an appreciation that there are finite resources. Resources are limited in a major way there. And I think, there's sometimes this feeling that we just have infinite resources here and we don't have to make any trade-off decisions in the States. And I think that's something that's just really done well there. And there's an open discussion with patients. Hey, this is something that, like back to your example, like this is something I think we could give it another week and let's see if you get better. I don't think we need really any blood work or imaging right now. This is similar to this viral thing that I'm familiar with. You're actually pretty stable. Let's go home and monitor for these things. And so I think there's recognition of the fact that there are finite resources and we need to be good stewards of those. I mean, I think that's something that they're world leaders in, that and the public health focus.
Travis, you recently just spun up a telehealth travel medicine clinic as well. Tell me, what was the inspiration for that?
Well, primary care, we do a lot of these pre-travel health consults, and I've always loved those because I've traveled a good bit myself. I've loved travel. I took my first solo trip as a 21-year-old and was just kind of hooked on learning and seeing new cultures, and then over time as a young physician, started realizing the things I needed in my drug bag and maybe didn't have, or went shopping at a pharmacy in another country and thought I have no clue what paracetamol is. Turns out it's basically acetaminophen. Okay, that's but learning those kind of like small lessons along the way got me excited about pre-travel consults. And I think there are sometimes pretty complex visits actually, and just basically the whole concept is to think about what are the risks you might face as a traveler if you're going into whatever country you're going into that's outside your kind of home culture or country. And that might be anything from air pollution in urban India to malaria risk in Eastern or Southern Africa, or meningitis risk. And so just talking through those and thinking about how do we mitigate those risks. And some of these things are actually more common than people think. So as the technology has gotten easier and easier to build, and as I've through more kind of just general primary care telemedicine practice, I've built up these 48 state licenses now. And so as the tech's gotten easier, I thought, well, surely I could build this dream pre-travel health clinic now. And I saw Michael Hobbs. I know you just did an event with Michael Hobbs. I saw him at JPM Week a couple months ago, and he was like, your face just lit up when you talked about this. And I was like, yeah, I've talked about it a lot and dreamt about it a lot, but I haven't really built it. And so with him and a few other people giving me guidance, I've kind of built, it's a very simple, cash pay only for right now. Basically, let's spend a lot of time together, talk about your risks of wherever you're traveling. I could send all the prescriptions, tell you what all vaccines or things you may need to get or update, and ideally mitigate risks so you can have a great time when you travel.
That's awesome. Yeah, I feel like a lot of people think a travel thing is just looking at a website and seeing if you need a typhoid booster, and maybe some azithro if you get food poisoning or something.
And a lot of times that is, but azithromycin, that's a great example. So if you have one bout of diarrhea, are you just going to start taking azithromycin? No, that's not evidence-based. So that's probably worth a conversation about when do you start the azithromycin or the acetazolamide for altitude sickness. Well, I'm going to be hiking at high altitude. When do I start the acetazolamide? And should I even take it given the other medications I'm on? I mean, there are things now that AI is, Claude is pretty good at capturing all this information for you and organizing it for you if you give it the right context.
Yes.
And so I think that's again, as that translator capability I like to talk about, that's a place where I think I can say, hey, let's take some of the AI generated outputs. Let's take things on the International Society of Travel Medicine site, the CDC's website, other websites, and the Travel Health Pro website that has malaria risk maps, and let's look at everything. Tailor the plan for you, and then you've got a little more confidence about all right, all the meds I'm taking, when do I actually use them, and maybe I don't need them at all as long as I stay hydrated and stay safe.
Love it. Travis, I've got 2 lightning round questions for you. Finish this sentence. The thing tech companies most consistently get wrong about physicians is...
The thing that tech companies most frequently get wrong about physicians is that we are stubborn and not willing to learn.
Okay, I like that one. Okay, now I've got the reverse for you. The thing clinicians most consistently get wrong about the tech industry is...
The thing that clinicians most frequently get wrong about the tech industry is that we're just a bunch of software developers and engineers building cool tools that we think are fun rather than things that actually fix problems.
Amazing. Dr. Travis Bias, thank you so much for being here. Travis, where can people find you, find your travel clinic, learn more about you?
Sure. So solventum.com is where all of our Solventum solutions can be found. And my travelhealthconsult.com is where my pre-travel practice is. So thanks for having me on, Graham. Appreciate it.
Thank you for being here.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.